fit in with the new agents such as beta-3 agonists. So I think from a pragmatic point of view, it will be a failure of conservative options, lifestyle interventions, fluid advice, and pharmacotherapy, which includes antimuscarinics and beta-3 agonists, and potentially combination therapy. But at the moment, there is no definitive consensus. So part of the problem in the past has been this cycle, antimuscarinic cycling. There was quite an alarming paper from the United States and Mike Chancellor's group that had suggested that actually in some areas of the United States, patients had been tried on 6 different antimuscarinics before moving up the pathway. And I think this kind of practice needs to stop, because essentially if you're not going to have an effective response with one antimuscarinic agent, it's probably best that you move on relatively swiftly. And I think now with other options available, this kind of practice should be discouraged. Recently, there's been 5 key studies assessing the combination of antimuscarinics with beta-3 agonists, Symphony, Synergy, Beside, and Melai. But if we focus on these 2 bottom charts here, what I can tell you is that the improvement in incontinence episodes is better statistically if you have a combination of an antimuscarinic and a beta-3 agonist. In these particular studies, it was a combination of solifenacin 5 milligrams and mirabegron 50 milligrams outperformed monotherapy. I've reviewed all the guidelines, and the EAU guidelines is what we tend to follow along with NICE here in the UK. And most guidelines would say once you've failed medications, options and refractory OAB options would include neuromodulation or botulinum toxin A. And after that, if these treatments fail, patients should be considered for urinary diversion or augmentation cystoplasty. These guidelines are pretty consistent, also similar in the ICI, AUA, and NICE. So I'm going to now focus next few slides on botulinum toxin A. The evidence base is probably best for this refractory overactive bladder option. There have been multiple randomized placebo-controlled trials, multiple systematic reviews and meta-analysis. So the evidence base is robust. The license indication is using the Allergan product of botulinum toxin A. And I should tell you there are several companies marketing different botulinum toxin A's, but the only current licensed one is the Allergan product, which is known as botulinum toxin A or Botox. And the licensed dose is 100 units for idiopathic overactive bladder. It is also licensed for neurogenic, and the licensed dose there is 200 units. The good thing about botulinum toxin injections, it can be given under local anesthetic in outpatients with a flexible cystoscope. It's a relatively straightforward, simple, minimally invasive procedure. At Guy's, we ran the first randomized controlled trial. This was a very small study, but it showed that there was significant efficacy, improvement in overactive bladder symptoms consistently, but also improvement in urodynamic parameters such as maximum cystometric capacity. One of the downsides, which was very much highlighted in this study, was that the intermittent self-catheterization rate was very high, around 37%. We knew that there was voiding dysfunction with botulinum toxin A, but this study really showed that it can be quite significant, with 1/3 of the pool needing CISC. Then Allergan themselves launched their licensing program. This was a dose escalation large study looking at multiple different doses. And this is ultimately how they push forward the 100-unit dose. But again, it did highlight this voiding dysfunction issue of around 20%. They then launched phase 3 randomized trials in Europe and America, 2 very large studies, about 500 patients each, in idiopathic overactive bladder. Very interestingly, these patients did not have urodynamics prior to being enrolled into the study. But what we could see is that botulinum toxin A was better than placebo at the primary endpoint, which was a reduction in urinary incontinence, urgency incontinence episodes at 12 weeks. They of course looked at quality of life as well, and using the King's Health questionnaire, there was significant improvements with quality of life in favor of botulinum toxin over placebo. Now, Looking at the voiding dysfunction that we just talked about, their study suggested this was far lower at 6 to 7%. And herein lies the problem, because the criteria for instigating clean intermittent self-catheterization in this study was very different to some other studies, including our study, for example, at Guy's. And so I think the CISC rate will be governed based on the criteria used to instigate it. I think a pragmatic approach would be that if patients are symptomatic and the residuals are over 200 milliliters, that probably is a reasonable indication to start CISC. But it's important to understand the different papers so that you can understand the variation in this adverse event. We've then gone on to publish the medium-term outcomes of repeated injections in the idiopathic cohort. We published this in European Urology almost 10 years ago now. But we were able to show that the repeated injections are consistently good. So at least up to 5 rounds of injections, we were still seeing improvements in overactive bladder symptoms. Allergan themselves then went on to conduct their far larger study of repeated injections, and the conclusions were very similar in that incontinence episode reduction was maintained over 6 rounds of injections, including patient satisfaction in the top picture here of around 80% still after 6 rounds of injections. Again, quality of life was also maintained. So in summary, botulinum toxin has got quite a lot of good data and good level 1 evidence data. It can give excellent therapeutic effects. However, repeated injections will be required, and you must counsel patients about adverse events. And the 2 common ones are slightly higher increased risk of urinary tract infection and voiding dysfunction needing intermittent self-catheterization. Now, in Europass, this may not be a big issue because quite a lot of patients may be doing intermittent self-catheterization anyhow, but in idiopathic population, this is more problematic. And actually, everyone has a slightly different practice. I tend to train patients with CISC prior to actually giving them their first Botox injection. The good news is it can be done as an outpatient, and discontinuation rates, although they are definitely there, it seems to me that repeated injections at least are good, and we are not seeing tolerance at the moment, which was one of the biggest concerns with this therapy. I'm going to move on to the other main refractory overactive bladder option now, which is sacral neuromodulation. There's quite a lot of consensus recently, and sacral neuromodulation is recommended for a number of indications. Of course, I'm going to focus on idiopathic overactive bladder, but it's also licensed for non-obstructive urinary retention. Colorectal surgeons and colleagues are using it for fecal incontinence. And of course, in selected cases, it may be a good option for urgency incontinence and fecal incontinence. So this is actually not new treatment. It's been around for a very long time, and the FDA have approved this in America for overactive bladder dry and wet. Looking at data, and there's been good data, which I'll just show you recently, suggests that efficacy is pretty good, around 85% efficacy for urgency incontinence, with dry rates approaching 50%. So as part of the FDA mandate, they had a sort of post-marketing study, which was quite a good prospective 5-year study about nerve stimulation, which was recently published in the last 2 to 3 years. And what we can see, these are the summary points. 91% of the population were female, as we may see in these sort of overactive bladder type papers. 80% were implanted. For those not familiar with the therapy, it's a 2-stage procedure. First, you put a lead into the S3, adjacent to the S3 nerve root, to see if you're going to get some efficacy for a trial period. If there is benefit, then what happens in the second, that a permanent battery is connected to the lead for the full implant. So when I mean 80% implanted, what I'm really talking about is the second stage success. Therapeutic success was 82%, which was excellent. Dry rate, again, approaching 50%. And importantly, we want to know about adverse events, and around 20% need re-interventions or go back to theatre for some reason. Permanent explantation over the 5 years was around 20%, and infection, which is another concern, was very low at 4%. Recently, there's been a systematic review of all neuromodulation for lower urinary tract dysfunction. And I highlight this study mainly to include the other type of neuromodulation that we use for overactive bladder, which is percutaneous tibial nerve stimulation. The criteria for entry into this systematic review was that you had to have at least 20 patients in your study and with at least 6 months follow-ups. There was some decent amount of follow-up. These were the selected nerve stimulation studies. I'm not expecting you to read this, but just to summarize that the efficacy was very good. And I wanted to focus on PTNS, which is the percutaneous tibial nerve stimulation. The evidence base for this is far less, but there are two very good studies, randomized studies, which suggested percutaneous tibial nerve stimulation performed better than oral antimuscarinic tolterodine, 79.5% efficacy versus 55%, and better than sham in perhaps what I think was the best study on PTNS, the Summit trial. So there is evidence base for PTNS as well, but it's just less robust in my view. There's far less data compared to neuromodulation, sacral nerve stimulation. There's been a number of innovations with sacral neuromodulation, which was much needed. The field was fairly static for a number of years, but in the last 10 years, we have now seen some innovation. This is the tine lead, which is what we deploy in sacral nerve stimulation. These are some X-rays to highlight the position of the tine lead adjacent to the S3 nerve root. You can see here, this is the old lead. The new lead has this sort of curve to it, which is essentially more anatomical. And there is now evidence and studies to suggest that the second stage implant rate is higher with this type of configuration. There's a whole plethora now of new technology. This was the old commonly used InterStim 2 Medtronic battery. We now have smaller devices. Another company has come onto the market called Axonics, which also have their own system. The advantages of the InterStim Micro and the Axonics system is that are now MRI compatible, and there are options for charging as opposed to battery replacement, because with the old technology, batteries needed replacing when they ran out. Some of the new companies, Stimwave, Nuvectra, are also bringing out their own neuromodulation systems. We're very lucky to have Susie as part of the faculty. Susie, as Professor Sharif suggested, is an expert in neuromodulation, worldwide renowned, and she was part of the body assessing the new Axonic system. This is the 2-year data that Susie published in Neurourology and Urodynamics, again suggesting that there's significant benefit for these newer systems at improving urinary urgency incontinence episodes, with again high satisfaction rates reaching 90% over the 2-year period. So what are the punchlines about nerve stimulation? Well, the success rate is equally good. And I would put the success rate with neuromodulation on equipoise with botulinum toxin. So there's significant improvements in overactive bladder symptoms. The safety is getting better, I think, with the new designs there and newer techniques. We're trying to get infection rates to less than 5%, which is good. We can take home these messages that revision surgery is needed probably in 1 in 5 in the long term, which is a good thing to sort of discuss with patients so they're fully counseled. And finally, we have these newer technologies which are better for patients. One of the biggest limitations in the past has been this MRI incompatibility. But now we have MRI devices, rechargeable devices, and finally we're moving in this field. The last study I'm going to touch on is the only randomized study comparing these two treatment options, botulinum toxin versus sacral neuromodulation. This was a great study designed and set up and published now from the States called the Rosetta study, and there's been quite a few offshoots. But this was a randomized trial comparing.
Sorry to interrupt, Sunny, just to let you know finally.
Brilliant, thanks, Prof. A randomized study comparing these two technologies. Interestingly, this is the 6-month data, which suggested there may be a slight benefit for botulinum toxin at 6 months versus neuromodulation improving urgency incontinence. But the 2-year data has recently been updated, and it's very interesting to see that over 2 years, the treatments are identical in terms of the primary endpoint in improving urgency incontinence. So again, good success with both treatments, no real difference between the two at 2 years. There was perhaps a better dry rate for botulinum toxin within the first year. I've sat on a number of think tanks and guideline committees in this area. This was something that actually we published 5 years ago about what we thought would be perhaps a slightly modified OAB pathway. And I think this still pretty much stands today. This was when beta-3 agonists were being launched. And to be honest, this is what I employ now, that if people have failed medications, then I would consider mirabegron now more as first line, only because there seems to be a slightly better side effect profile. Then we can switch things around to either antimuscarinics or beta-3 agonists, depending on what they've had first. I don't think we should delay in this area too much. Keep trying different pills if they don't work. Patients should be moved on. They should be discussed about combination therapy. And if they're happy to take more medications, that's a good option. And if not, again, they should be discussed all refractory overactive bladder options. That you should give patients the information about PTNS, botulinum toxin, and S&M. My final point will be that if you don't have access to some of these treatments, then perhaps if other people do, even within your areas, then it's probably sensible that they get opinions if they're interested in that. But they should at least be counseled about all options. And of course, cystoplasty or diversion for those that are refractory to that. Many thanks for your attention. Thank you.
A very informative summary, I have to say. I mean, 20 minutes is never enough.
Yeah.
But certainly you did a great job, and thank you. Just one or two announcements before we move on to the next speaker. General feedback has been, I have to say, very, very good, excellent. But can I ask the audience to please fill out the actual questionnaire survey online so that we can give you more formal feedback. We've had about 1,640 people that registered. Usually we get about 40 to 45% then coming online. So the number that have actually been online is just under 300. It goes up and down. We get a live count. Okay, so which is actually very good. Can we keep the, this is now to the audience. It's great to see excellent feedback, but can you focus on some questions for the question and answer session that I can put to the speakers a bit later. So without further ado, let's move on now to the next speaker, and that's Rahila Rizvi, who is a gynecologist at the Aga Khan University Hospital, Karachi, Pakistan. She has a particular interest in this area, and